Hey guys, this is Josiah. Got another video for you here. I wanted to talk a little bit about COPD, chronic obstructive pulmonary disorder or disease. Okay, so what exactly is this? So here is a picture of the lung anatomy. We have the trachea, if you can see my pointer, the left and right bronchus. Then off the bronchus we have these what are called bronchioles that lead to these little tiny grape-like sacs at the ends. And this is kind of a blown up picture. So here's the bronchioles. And at the end, the grape-like sacs surrounded by blood vessels. So this is where air exchange happens of the CO2 and the oxygen. The bronchioles do not participate in gas exchange. But what's significant about the bronchioles is it's made up of muscle. And this muscle can contract or expand to open or close the airways. Also, inside, along this, which is not shown, these cells that line this can secrete mucus to help move airway particulate upwards to be able to cough out or swallow, which is gross, but that's the truth. So what exactly is COPD, chronic obstructive pulmonary disease? Well, it's actually two diseases in one. We have emphysema, which is a common term a lot of people have heard, which essentially is the permanently loss of alveoli, these little air exchange sacs in the lungs. And you can imagine that if you're losing air sacs, you're not going to be able to exchange oxygen and carbon dioxide as well in your lungs. And the side effect is you're losing tissue, and at the same time, there's an expansion of those alveoli, so they're no longer compact, and you're losing tissue, so there's gaps in the lung essentially. And I'm going to show you what it looks like on a CT scan in a minute. But essentially this occurs because there's hardening and scarring of the lung tissue and immune system reaction that's coming in, and actually your immune system is helping destroy some of this. And the most common cause of this obviously is any cigarettes, any type of smoking, fumes that can come in. We see this in coal workers, miners, anything that, even grain, people that work with grain, they're breathing it in. And then rarely, on the bottom here, A1 antitrypsin deficiency. So A1 antitrypsin is an enzyme to help keep the immune system under control within the lungs and help protect the lungs from basically harmful reactive chemicals that we inhale, essentially. And that's a rare cause of COPD. The most common cause is tobacco. And so the bronchitis part of it, so we just discussed the emphysema. The bronchitis is essentially these mucus cells overproducing mucus. And you can imagine if you're making too much mucus, it's going to actually obstruct these little areas and make it harder for air to exchange. The other side effect of this is all that mucus has to go somewhere. So the lungs have a protective mechanism not to allow that mucus to come down into the alveoli, these berries where gas exchange. So we're going to be coughing mucus and phlegm up. And that's what the bronchitis is. Essentially, it's called chronic obstructive pulmonary disease because we can't get the air out. As we're losing the alveoli in the recoil of the lung to move air out, we basically start to dilate the air, and we have a gas exchange problem. So let's see what this looks like on imaging. Here's another example real quick of what this mucus COPD bronchitis forms. A nice healthy open airway, some mucus to help move particulate. But as we develop this bronchitis from the obstructive disorder, we narrow the airway with excess mucus. And you can imagine if excess mucus is present, the bacteria that naturally live in our airways or bacteria that we bring down into the airways has a nice place to grow in form of pneumonia, which is a common side effect to COPD. So let's take a look at these CT scans. So we have a normal, healthy lung. Now this is an axial image, so it's kind of like if you took the human body and sliced it up like, I don't know, a smoked sausage. That's the view. So we cut the body in half and we look at it like that. And so we're looking from the feet up here, and we have the heart and we have the lungs. Left lung and right lung. Here's ribs. These white areas are ribs. Here's the spinal cord here. But what we're looking at here is we can't really see the alveoli, but it's between these little bronchioles coming down here, these little tiny white lines. These brighter lines are actually artery coming off the heart. You can see some of that here. But if you flip over to the left side here, on my right, look at how this lung tissue looks different than the CT scan of a healthy lung. You'll see these big, wide, black gaps here. That's loss of tissue. That's essentially emphysema. So all this can no longer participate in air exchange, and it loses the connective tissue that helps recoil the lung. It's kind of like underwear that you've continuously stretched out and now they're too wide to stay on your body. This is exactly what's happening with the connective tissue and the emphysema. Let's go down here and take a look at these chest x-rays. So we have a frontal view and we have a side view from coming in from the side. So this is a nice healthy lung. We can count all the ribs here. The diameter is not abnormal. Look at the side, so we can actually kind of see in front of the spinal cord here, the heart's here, a nice diameter. Now come over to these here on the COPD patient. Notice the spacing between the lungs. The lungs are expanded out. If you compare that to the rib spacing here to here, you'll see that. Now look at the side view. Look at the diameter here between the spine and the sternum, the front of the chest, versus a healthy lung. So you can see that it's obstructive. You can't get the air out, so the air just keeps increasing as you breathe in over time. Now this is a slow process. The diameter of the lung, and they will physically show a hyperinflated chest from both dimensions to some degree. Predominantly from the side view is going to be wider. So what are some signs and symptoms? Well, because the number one reason is some type of smoking, whether it's tobacco or whatnot, this occurs in middle age. And the main symptom that brings people in is they're feeling short of breath. They're taking a walk and they're feeling worse with their breathing. They're having trouble getting air. Things that used to not be a problem, now it's they're short of breath. Some people will chalk it up to old age, but a lot of times that's not necessarily the thing, because I have met plenty of 90-year-old people that can go out and take a walk without getting short of breath. Here's the one thing that is worse, because we get all that mucus, is this chronic cough, meaning it's every day. And it's always worse in the morning when they're waking up. They're hacking, they're coughing, trying to clear that mucus out that's collected overnight from essentially sleeping. And tons of sputum. So my memory aid that I've used to help diagnose the symptoms is I use the word COPD. The D is small here because I don't worry about it, but the COP, so like cough, obstructive breathing, which is essentially saying shortness of breath, and the phlegm. Those are the three main symptoms. Now the problem with all this bronchitis, the excess mucus, as we talked about, is infections. So it's very common for COPDers to suffer like a pneumonia, an acute case of bronchitis, severe with fevers, cough, chest pain, the whole works, multiple times a year that can end up being hospitalized. How do we diagnose this? The number one way to diagnose this is through what's called pulmonary function testing. So if you look up at the picture on the right, this is what this is showing. The lady is basically doing a breathing test where she takes a deep breath as deep as she can and blows out as hard as she can, and this device will measure that expiratory flow. Remember, it's obstructive. We can't get the air out. That's why we get dilated lungs. And so this machine can measure the first second of airflow out, and then over the next 5 to 10 seconds of how much air is coming out. And so then you can compare this to a healthy person and determine how much less air they're essentially moving out of their lungs to help diagnose it. Now, as a clinician, you're obviously going to get a chest x-ray just to rule out other causes of shortness of breath and phlegm, as there's many causes of this in the differential. Shortness of breath, obviously heart failure can work in there. Now, COPD can result in a heart failure called cor pulmonale, which is essentially the right heart failure because of how the circulation goes from right heart through lung, then left heart into the system. So let's talk a little bit about the pulmonary function testing. So once again, here's that picture of that lady taking a deep breath and blowing out as hard as she can. Now what we're measuring is two things. We're measuring the FEV1. And this is just a fancy name for how much airflow that first second comes out. And you can see that in this graph here. Let's say that this is the first second up to here, from here to here in a normal healthy person. This is how much airflow came out under that first second. It's a hard breath out. Versus an obstructed person in the first second, you can see how little air they're moving out in that first second. So that's the first marker. The second marker is the FVC, forced vital capacity, and that's just a fancy name for how much air, total air, you can press out after a deep inhalation, deep breath, over 5 to 10 seconds. A lot of times it's the first like 5 seconds or so, 5 or 6 seconds that you'll get most of your air out. And you can see this in this chart. A normal person, here's the first second, rapidly blowing out air, and then it kind of plateaus, and what they're not showing is the final drop off. Look at how the obstructed person is. Can't get much air out that first second, and then the FVC over the 5 or 6 seconds, they're kind of plateauing off. But look at the difference in the total airflow for volume. This obstructive COPD patient is putting out half the total air, breathing out as hard as they can as a normal person, and that's technically what COPD is. So we take those two numbers right here, highlighted in yellow, FEV1, that first second, how much volume, divided by the total volume of time, and we divide that. If that ratio is less than 70%, that 0.7, we have the diagnosis of COPD. A normal person can do this about 80%. That first second will basically eliminate 80% of that air that's in the lung after hard breath in and then hard breath out. So that's kind of what we're doing with this. Now, the diagnosis of the category of how severe the COPD is here on the GOLD classification. So what we do is we've had the diagnosis with the FEV1 versus FVC. It's less than 70%. You got COPD. How bad is it? Okay, so they know the predicted first second of breathing out on almost all people. Somebody smarter than me figured out height versus age, how much lung volume you should be able to exhale, and set a standard normal. Now, we know with the COPD that FEV1, that first second, they're not going to move as much air, and so we're using that against healthy people to predict the severity of the COPD once we have that diagnosis less than 70%. So look at the chart. GOLD 1, mild. That first second of breath predicted against a healthy person 80%. So if they're hitting that 80%, which this is not showing, this line would be more up in here, that's a very mild case. Now look at the severe. The first second, less than 30% predicted of a healthy person, that would be in this range. So we can see that with this person, this obstructive disorder is very severe. That first second of time, they're not able to get enough air out. And so we can kind of get the severity of the COPD. Now, they do give you, during this test, they're going to have you do this twice. They give you albuterol, essentially. Asthma is reversible, meaning that you do your first test, say this is me, and I think I have a COPD. I do my first test and I can't get air out. Okay, now they give me some albuterol, and I do it again, but I improve and I'm more normal. That's reversible airway issue after the albuterol, which opens the lungs up. That's asthma. That's not COPD. COPD does not improve with albuterol. So we have a permanent damage to the lungs. Albuterol is not going to reverse that. Okay, once we get all that information, back to that little chart we saw, we get the severity here. The second thing the clinician does is they have a survey done by the patient. And we call this the MMRC right here. So you'll see that on this scoring tool. So here's the MMRC, assessing disability in COPD. We ask the patient, are you breathless with strenuous exercise? Grade 1. Short of breath when hurrying on a level or walking hill? Grade 2. Walk slower than people the same age. So you're basically surveying these people, and they're going to click each box if it's a problem. Well, we take that and we score it 0 to 5, and we look at that in this chart here of how to actually start pharmaceutical for COPD. So we need to know the MMRC. So we have A, B, C, D. What's the MMRC? Did they score equal or greater than 2? If they did, we're no longer in this group here. We're going to be either in group B or D. How do we decide that this person that scored 2 or more on the MMRC, this survey, is either group D or B? Well, look to the left. Have we had greater than 2 exacerbations? Now, what's an exacerbation? It's a severe pneumonia bronchitis from that mucus that collects in there, and we get very sick. So have we had this in the last year? 2 or more moderate exacerbations that required treatment, including antibiotics usually, or have we been hospitalized more or equal to 1? If that, with the score of this survey, is greater than 2 or equal to 2, that puts us in grade D. Now, D is worse than C, B, and A. And that's going to step up the pharmaceutical treatment. 0 to 1, let's come back. Say they scored this MMRC equal or greater than 2, that survey. I look over here. Have they had 0 or 1 moderate exacerbation not leading to hospital? Then I can place them into group A or B, and this, with the MMRC of greater than 2, they would be in a B, that I'm going to prescribe a LABA or a LAMA. Now, if they're already in a LABA or LAMA, that the clinician has to make judgment. But anybody that's had hospitalization in the last year is going to be moved up to grade C or D. So that's kind of how you use this chart to determine pharmacy. Now, I do want to talk about treatment, and it does get a little more in depth, but let's step back for a sec. Once again, we have the trachea, we have the left and main bronchus and right bronchus here, the bronchial, and these little grape-like sacs that exchange gas. So here's the bronchioles with the muscle, here's the alveoli where we exchange gas. Now these muscles are important. So when you prescribe inhaled medication, we're essentially targeting these muscles to help them dilate. It won't necessarily clear up the mucus, but by the dilation of that, it'll allow air to move out better instead of getting trapped in the lung. And so we have 3 main inhaler medications to affect the muscles on these bronchial here to open up the lung. And they're abbreviated SAMA, which is a short-acting beta agonist, which essentially is albuterol. That's how people know it. A LABA, long-acting beta agonist. So it's a long-acting albuterol. Albuterol may only last for a few hours. A LABA can last 12 hours. It's a long-acting, essentially, beta agonist albuterol. Then we have the LAMA. So this is a long-acting muscarinic antagonist. And so what muscarinic system does is when we're at rest, we don't need a lot of air volume. So it'll kind of constrict some of these airways to help be more efficient in the lung. Well, when we antagonize this, we block this, the muscles relax and open up. So we could force open it with this beta, so adrenaline system, by when we're under fight or flight, our lungs are going to open. We can force that by triggering those receptors to force it open. And then we can block the rest and digest muscles to help open it. So we can actually work on 2 separate pathways if we prescribe both of these medications together. So I want to talk about non-pharmaceutical treatment, and then we'll jump back to the meds. So things that we need to tell the patients, or if we're suffering this ourselves, is we do need to exercise. So exercise, mild exercise, multiple times a week has shown to improve lung volumes, reduce inflammation, things like that. The number one thing we need to do there is we need to figure out how to get off whatever we're inhaling, smoking, it can be cigarettes, marijuana, whatever we're dealing with, inhaled pollutants. We need to avoid those. We may need to be concerned with our air quality in our home. Healthy eating reduces inflammation in the body. COPD is an inflammatory disease, usually caused from smoking or some other pollutant. We can use oxygen if they're normal. This patient's normal is less than 88%. Oxygen has shown when we have an SpO2, that little thing that we measure oxygen, less than 88% will extend their lifespan. Now, if me or you are sitting at 88% and we don't have COPD, I would be very concerned. But these people have learned to live on a lower oxygen level because they retain CO2. The other thing to consider is sleep apnea. So a lot of people, if they're having sleep trouble, they're blocked airways at night, it's going to worsen COPD. So a sleep apnea test is definitely recommended if there's any signs of that. So let's take it back up 1 second. Let's go back. Here's another copy of how to treat the pharmacology treatment of COPD based on that MMRC, that survey of shortness of breath and whether they've had exacerbations and hospitalizations. So the group A is the person that's literally just taking albuterol and they're doing fine. So these are some the albuterols that we're kind of talking about, the short acting. There's multiple types, but essentially it's albuterol. We have the group B, so either a long-acting LABA or LAMA, like we talked about. Do we want to encourage the adrenal system to open the lungs, or do we want to block the rest and digest to force the lungs open? And so here's some LAMA and LABAs. The increase elliptica is very common right here, a LAMA. Even the Spirivas are LAMAs there. Those are fairly common brands that people know. Respimat is on there. It's pretty common. Now, if you're stepping up, say that you had a LABA, you're group B, but now you're in a group C, the LAMA, you can use either or, but usually it's a LABA on top of the albuterol, then stepping up to this LAMA to block the rest and digest to open up the airway. Now, if we have a patient that is not doing well and they've stepped into group D, we're going to use both the LAMA and LABA. You can get them together in one inhaler. So if you look here, this is LABA and LAMA in one inhaler. Here you got the Norellipta. So this is fairly common. It's got, instead of having 2 inhalers, you have essentially 1 inhaler. Now, some people stepping up from here, we're going to add an inhaled steroid. So there's 3 drugs. We have the inhaled corticosteroid, we have the LAMA, we have the LABA, all mixed together in one, and one of the brands is called Pathology. Now, if you look at this chart, it's basically encouraging that if we have an eosinophil, that EOS 300, so that's an allergen reaction, the steroids will help with that, much like an asthmatic patient. But the steroids have not shown completely helpful for all COPD patients. So I just wanted to talk a little bit about that. If you have any questions, I know it seems kind of complicated with the medications, feel free to reach out to me, and I appreciate it.